Hello, everyone. Thank you for joining us this evening. I see that one of the people write no sound. I hope that you're getting along and you can hear us. My name is Irit. I'm the VP of Marketing in AB Dental. And today we are having a webinar with Professor Angelo Cardarelli that is here with us from Italy. The subject of the webinar is about customized implant. And I would like to thank the professor, first of all, for joining us and also sharing his knowledge with us. And I would like to invite him to start his presentation. At the end of the presentation, we will have questions and answers session. So for now, I put all of you on mute, but at the end, we will give you the option to unmute yourself. So you will be able to ask questions or say anything to the professor. So thank you so much, Professor Angelo Cardarelli, and you can start your presentation.
Thank you, Irit. Thank you, everyone. It's, as usual, a great pleasure for me to be here and to share my experience with AB Dental implants and with the AB Dental products. And as I told during the last amazing event in Athens, with AB Dental, we have the possibility to choose different devices, different implants according to the different clinical situation that we can have. And today I will share with you and I will show some cases using the customized and subperiosteal implant. This is a new approach in order to treat patients in which we don't have enough bone. So challenging case that we can treat now using customized implant. And I will show how we can do. Because as you know, sometimes, especially in old patients, we don't have enough bone. So which are the options that we can have in order to treat this kind of patients? We have different approach. So we can use the residual basal bone of the patient. So we can do, for example, the all-or-mix procedure. So, for example, in the maxilla, and evaluate this short video in 85 years old patient. Can you imagine in this patient if we are doing something invasive, something different? Now we can use only the residual basal bone of the patient, placing 4 implants in the atrophic maxilla, and we can do immediate loading, immediate static, and immediate function in only one step. So this is one approach. If we don't have enough bone in the posterior side, so we can use the bone in the anterior, and let's see this video using a long implant. In the posterior, I used 18 millimeter in terms of the length to achieve the primary stability in the nasal area. Why? Because there we have a good primary stability. And as you know, we need to have at least 35 Newton in order to make the immediate loading after the implant placement. And actually, and we can do the same with the customized implant. We can use the digital workflow. So after implant placement, we can take the impression using the same scan body that we are using, for example, in this case, in an all-or-mix procedure. Then we can send our STL file to our dental technician, and within 72 hours, usually, this is in my protocol, we can receive this temporary restoration in order to make immediate loading and immediate restoration with immediate static and immediate function. But as you know, sometimes we don't have also enough bone in the anterior. That's why we have another option. In the past, we did many kind of those surgeries, so we can harvest the bone from the head and we can make some bone regeneration exactly like this. But you can see that it's a very invasive procedure. And especially if we have old patients with some systemic disease, as you can imagine, it's impossible to make this surgery. We have a high risk. That's why instead this kind of bone regeneration, another approach is zygomatic implant, for example, in the maxilla, for sure. But as you know, in the zygomatic implant, the problem is related to the complication. Because if we have some complication with the zygomatic implant, it's very hard to solve, and also we can have a lot of problems. That's why now we have another option. We can use the customized implant, reducing the invasivity, reducing the morbidity, but maintaining the same outcomes. I don't know if you have heard before about the customized implant. The customized or subperiosteal implant is an old concept, but now we have something new. Basically, the customized implant or subperiosteal implant is the same name, is titanium framework, and I will show the difference from the old concept and the new concept in order to understand why now we can use this way in order to treat this atrophic patient. Okay, so old concept with something new. And let's see those kind of old customized implant. You can see the different shape. Also, the surface is completely different. Poor quality in terms of the surface. And this is the future. This is how we can use now this new concept about customized implant. The important difference also is in the prosthetic part, because in the past it was impossible to use a screwed retainer restoration. So using the old subperiosteal implant, it was possible only using the cemented restoration. And you know which is the best option in implants rehabilitation, the screwed restoration. Why? Because we can reduce the micro movement and we can avoid the cementation, and avoiding the cementum, we can reduce the risk of the infection, mucositis and periimplantitis. So we can increase the successful rate of our implant. This is one of the differences. In the past, another problem was related to the stability, because in the previous customized implants type, it was not included the screw to fix and to stabilize the customized implant. But as you know, if we have some micro movement, we will lose the stability and we will lose also the bone. So we will have a huge soft tissue exposure, infection, and failure. Now it's different, and I will show some cases in which we can use many screws according to the clinical situation in order to fix and in order to stabilize this kind of customized implant. And again, the surface, it was completely different. This is the past. Have a look. Infection, exposure, cementum inside the soft tissue, and failure. Have a look at this OPG. Can you understand the bone resorption related to the mobility of this customized implant? And also have a look. In this case, you can see that we have only one piece, but it's better to split, to divide in two pieces. Why? In order to reduce the tension. That's why if we are using this approach in the full maxillary rehabilitation, it's always better to use two pieces, to split in two parts in order to reduce the tension. This is another important thing, but I will explain later on during the lecture. Also, it's different, the manufacturing, it's completely different. Now we can use the CBCT, the 3D approach, and the laser sintering process. Using the laser sintering process, we can have a very precise customized implant, and we can have a very precise fitting on the bone. And if we have this precise fitting, we can reduce the micro movement. Okay? Again, now we can use this kind of titanium, titanium grade 5. It's completely different compared with the past. And this is one of the cases that I will show later on. But anyway, this is the new concept of subperiosteal implant. We can treat small edentral site. In this case, we are in the upper jaw on the right side. We don't have enough bone. We have the sinus cavity. So we are planning to place this kind of customized implant with 3 multi-unit abutment, fixed with the 7 screw. The screw of this implant are always the same in terms of the diameter, 1.2. The difference is the length. So we will have a different length according to the residual bone that we have. And I will show what I mean. But just few words about the surface. Now, using this rough surface, using this chemical treated surface, we can allow the osteoblast to produce osteogenic and angiogenic factors to improve also the osteointegration. This is one of the big difference with the previous concept, the old concept of customized implant. And as I told before, which are the indications? For sure, in my practice, for example, I'm using the customized implants in old patient, in the patient with some systemic disease, in which it's impossible for many reasons to make bone regeneration, for example. Or actually, instead in the maxilla to use the zygomatic, I prefer to use customized. Why? Because if I have some complication with the customized implant, it's easier to solve, it's easier to manage. This is the important thing. This is not only the surgical procedure, because as you know, if you have some surgical skills, also with the zygomatic implant, you can do it. But the problem is if you have some problems, some issue. If we have some issue, be careful, because with the zygomatic implants, we can have a huge complication, and also it's not easy to remove. Sometimes we need to cut the implants and to leave the apex in the zygomatic bone. Can you imagine the problem for our patient? So basically, all patient with some systemic disease in which we don't have any other alternatives. And which are the contraindications? For sure, we need to see the health of the patient, and also we need to avoid any surgery in the patient with chemo and radiotherapy, or in the patient in which we have some systemic disease, related to the bone healing. Okay? But again, why subperiosteal implant? Because now the framework, the titanium framework is very, very precise. So we don't have any problem in terms of the fixation. The fitting is perfect. We can make also immediate loading. We can reduce the surgery in only one step. Okay? And we can solve an extreme case in which we don't have any possibility to place the standard implants in order to rehabilitate our patient. For sure, for the beginners, it's something challenging. What I mean, we need to have some experience about the surgical field. We need to have some experience in terms of the flap design procedure, because sometimes we need to open more in order to see the bone, and we need to understand how we can use some anatomical structure. For example, in the maxilla, my advice is to use the fat that we can have in the thickness of the cheek, because with this fat we can cover the customized implant and we can reduce the risk of the exposure. That's why we need to know how we can reach this fat in the cheek, how we can make the suture, how we can close the customized implant, because the common mistake and the common problems related to the customized implant is the soft tissue exposure. And if we have the exposure, we can have different scenario. If we have a small exposure without infection, we can keep the customized implant just to see the patient very often in order to see if we have some infection and to keep very clean the customized surface. Or another option is to cut the part of the customized implant that is exposed. Obviously, if this part is not involved in the prosthetic part. If you have big exposure, big infection, sometimes we need to remove. That's why it's important to plan correctly from the beginning. What I mean, the selection of the patient is the first things that we need to follow. We need to see the patient, we need to see the opposite arch, we need to see the quality, the quantity of the soft tissue. Another difference is, as I told before, in the production of those customized implants. Because as you know, in the past, in order to place the customized implant, it was necessary to make two surgeries. The first surgery to open the flap, to take the impression, and that's it. Then the closure. After that, after the production, we need to open again using the impression of the ridge, and then we can put the customized implant. So it was necessary to have two different surgeries. Actually, nowadays, it's completely different. Why? Because using the 3D, the digital workflow and using the CBCT, we can, from this CBCT and with the laser sintering procedure, we can receive this amazing 3D printing model with this plastic guide, and I will show how we can use this guide, and we can receive the final customized implant made in titanium that we will fix later, and I will show. This is the process. So this is the machine that Evidenta has in the factory, and for the first time we can produce those customized implants starting from titanium dust. From titanium dust with the laser sintering process, exactly as I'm showing now, we can produce the final framework like this. So laser sintering. That's why when we will put the customized implant, it will be very, very precise. But have a look how we can use those products in our daily practice. Another different, for example, for the zygomatic implants, it's better to make this surgery in the general anesthesia in the operating room. Instead, I'm doing this surgery in our private clinic. For sure, I'm using the conscious sedation, but we don't need general anesthesia. We can do this surgery in our private clinic using the anesthesiological support and using the conscious sedation. And if you have a patient like this, 75 years old, in which in the upper jaw on the right side, we don't have bone, we have only the sinus. So how we can treat this patient? Avoiding bone regeneration. Because if we are planning to do the bone regeneration in this patient, we need to make vertical augmentation. Why? Because we have we need to fix the vertical dimension. We have an increasement of the intermaxillary relationship between the upper and the lower jaw, and is something challenging. So From the CBCT, we can receive from AB Dental our project. So we can see the project. This is the previous project that we're planning to use and to make in this patient. As you can see, we have 5 screws, 2 on the palatal side, 6 screws, 2 on the palatal side, and 4 on the buccal side. At this time, you can decide to go ahead and to produce this implant, or you can make some changes. And I did in this case. Why? Because I prefer to have more extension here in the zygomatic area. Why? Because if we have more extension here using a long screw in the zygomatic bone, I will have more stability. And if we will have more stability, we can reduce the macro movement, we can reduce the bone resorption, and we can reduce the failure rates. Okay? So we can change the project. Now, according to my opinion and according to my planning, it's correct. So within 3-4 weeks, we can receive the final customized implant with the 3D printing model. And I want to show this 3D printing model in order to understand how we can perform a very precise surgery using this guide and using this customized implant. We have a perfect fitting, and I will show here this palatal side, because when I will open the flap in the patient, we will see the same shape, and the fitting, it will be perfect. This is our goal. Because if the fitting is not perfect, we need to avoid the surgery. There is no way. It's impossible to change during the surgery the shape of the customized implant. Absolutely no. That's why we need to be precise. And regarding the maxilla, as I told before, I'm using always the fat that we have in the thickness of the cheek. And here in this small video on the cadaver head, I will show how we can reach and how we can find this fat in the cheek. We don't need to cut, just to release. Why? Because with this incision, we can release more the fat, and with this flap, we can cover the customized implant. And we can create a double layer. The first layer using the fat, covering the customized implant, and the second layer using the flap, covering the fat and the customized implant. Why? Because with this fat, we can cover better, and we can protect the customized implant, and we can reduce the risk of the exposure. And for sure, we need also to make periosteal incision, both fat and periosteal incision. Why? Because I need to increase the length of the tissue. We need to avoid any tension, because if we have a tension, we will have a we will have a exposure, and we will have a bad healing. So let's see, after 1 month, we can receive from AB Dental this package in which you can find everything from the planning to the prosthetic part. So 3D printing model, plastic guide, screw, drills, analog, digital and analog if you are using the digital workflow, and the scan body if you are using the same approach. Okay, so everything is inside just to start the surgery. We have already in the package all the tools. And this is the package in which we have the customized implant that we will open before the fixation, as I will show later on. And then we have, I will be more quick, the 3D printing model. Again, you can see here this plastic guide and how we can use the plastic guide. For example, I'm using this plastic guide before to place the titanium customized implant. Why? In order to understand if our flap is enough in terms of the extension, and also in order to understand if this customized implant is precise in terms of the fitting on the bone. Okay? So this is our 3D printing model. Now this is the surgical scenario. And I will show again this model, because when I will open the flap, we will have the same shape. Okay? So let's start the surgery. The important thing is the incision. Have a look here, the incision. We need to be more palatally. Why? Because I want to move this tissue from the palatal to the buccal side. And for sure, we need one incision on the distal side and one incision on the mesial side. So trapezoidal flap. Why? Because I need to open more. I need to make the exposure of the zygomatic bone, because in that area I will place the longer screw that it will be 13 millimeters. Then slowly we can start with the flap incision. And as you know, in the edentulous site, usually we have a fibrotic tissue. So we need to use the clamps and the periosteal to release this fibrotic tension, avoiding any perforation. Because if we have a perforation on the periosteum, we can have high risk of exposure. That's why we need to preserve the periosteum. So slowly, full thickness flap, like this. And have a look now. I'm using this plastic guide just to understand if this opening procedure is enough or not. And as you can see, it's not enough. Why? Because I need to open more here. And this yellow tissue is the fat. Okay? Here we have the sinus. Here is the sinus. The bone is very thin, so we don't have a bone here. And again, you can see here the periosteal incision to increase the length and the extension of our flap. Here we can see the fat. Now the view is much better, and we are ready to place the subperiosteal implants. And this is the fat. And you can see that when I will put the customized implant on the bone, this means perfect fitting. The customized implant is already stable. Why? Because the fitting on the bone is very precise, is perfect. So it's already stable, and it's very easy to stabilize using the screw. We don't need to do anything else, just to put on the bone and to start with the screw placement. Okay, so now we can open the package. Here we have two multi-unit abutments. And then I will put the framework, titanium framework, the customized on the bone. And it will be already stable. This is the shape. So we have 7 screws. Same diameter, 1.2, different lengths. The longer one, it will be on the zygomatic bone. For the same reason that I showed before. Have a look now. No screw now is already stable. It's amazing. Now, using the fingers, we can keep the customized implant close to the bone and we can start the screw placement, okay? In order to stabilize the implants that is already stable, okay? Inside the package, we will find also this drill that we will use for the screw placement. Then we can screw all of them. For example, this is 5 millimeter according to the CBCT. And we have 5 screws on the buccal side, 4 screws on the buccal, and one of them is on the zygomatic bone, one in the posterior in the tuberosity, and 2 on the palatal side. But now it's very easy just to complete the screw placement because it's stable. The customized implant is stable. We don't have any problem in terms of the micro movement and in terms of the stability. Means easier procedure. Okay? Here you can see now we have the gap between the customized implant and the bone, but when I will put the screw inside, you can see that this customized implant, it will be close the bone. No gap. No gap. And how we can check after? Also with the CBCT, because with the CBCT, with the follow-up, we can see if we have some gap between the customized implant and between the bone. And we don't have, but I already show it in the clinical part. Okay, so just complete the screw placement. This is the posterior. Here the bone is very soft, and 2 on the palatal side. Why there is no rules in terms of the screw placement? So we can put the placement is random. But in the case like this, I prefer to put as last screw, the screw on the zygomatic bone in order to reach the final stability. And have a look here. The bone is harder compared to the other parts. Then we can place the screw, 13 millimeter. But after that, it's not enough. Now we need to spend time for the soft tissue management. So we need to release the fat. We need to use the fat to cover the customized implant. You can see here how we can reach. So small incision using a new blade. Then we can reach and we can make the exposure of the fat inside the cheek, exactly like this. No cutting, be careful, but just to release and to move on the top of the customized implant using a resorbable suture 4-0 to create a double layer. You can see the mobility of the fat. More incision. And now have a look with the suture. we can move and we can fix, we can keep the fat on the top of the customized implant, exactly like this. After that, we can complete the closure using the suture to close the flap, like this, okay? Resorbable suture, and this is the final sutures. And here you can see that I want to be sure that here we have enough connective and keratinized tissue. This is the post-op OPG, okay? In that case, I didn't make immediate loading, so just wait 6 months to take the impression with the scan body, buccal view and occlusal view to understand the healing and the closure. This is 6 months later. Then we can use the temporary before, then we can finish with this screwed bridge with ceramic. This is the CBCT after 6 months. Have a look. We don't have on the right any gap. Again, no gap. Perfect filling. This is the proof that the customized implant is perfect. The fitting of the customized implant is perfect, and we don't have any gap. And this is the final result, the final OPG. Final bridge and occlusal view, okay, to finish this case. And also we published this case in the latest magazine in US. So you can find also this publication, this clinical case in Digital Dentistry and Health Knowledge magazine in US about the use of customized implants in the atrophic rehabilitation. But for sure, we can use also in huge rehabilitation. So full maxillary rehabilitation in the case like this. Have a look at this patient. No bone in terms of the height and in terms of thickness. So what we can do? We are planning to place 2 customized implants, not one piece, but 2 customized implants, as I told before, because I want to reduce the tension. Okay? This is the model. This is exactly the same. Okay? So from the CBCT, we can receive this 3D printing model from AB Dental. In that case, we have 2 customized implants and we have 2 plastic guide. Okay? And we have 25 screw to fix the customized implants in that case. Okay? Like this. One on the left and one on the right. 6 multi-unit abutment. 6 multi-unit abutment. Okay? This is the plan. 12 screw on the right and 13 on the left. Total amount 25 screw. For the surgery, the flap is a little bit different. Why? Because we need to open more and we image the exposure that we need to have to place two customized implants. That's why we need to make one incision in the medial part and two vestibular incision in the distal part to open and to see both zygomatic bone areas. Okay? Like this. And again, as usual, we have fibrotic tension, fibrotic tissue. So slowly, slowly. Then we can open the flap and we can fix exactly the same that I showed in the previous case. The difference is the number of the screw. We have more screw for sure, but the approach is exactly the same. Last drill in the zygomatic, right and left side. The longer one, as usual, is in the zygomatic bone. Okay? Again, fat to cover both sides. Exactly the same. And I will show the suture. The suture here is very important. So we need to close before the medial incision. Then we can use the modified vertical mattress to hold the tissue around the healing cap. 40 resorbable sutures. Okay? Can you see now the closure? This tissue will become new keratinized tissue. So don't forget, we need to be careful in the closure. Final post-op OPG. 6 multi-unit abutment and 25 screw. Before and after. But have a look at the CBCT. That's amazing. No gap. Perfect filling. Again, this is the proof of the precision of this framework. Titanium framework is perfect in terms of the fitting. This is the case. You can see that we don't have bone. Nasal cavity, can you see? And have a look also, the palatal view is perfect. The fitting, again, is perfect. Okay? Then the closure. Then the impression for the immediate loading. So we can use the digital scanner to make the impression. Can you see the healing of the tissue with the temporary, the occlusal view, and this is the temporary with PMMA. Okay, smooth surface to allow the healing of soft tissue, and that's it. And this is the patient with the temporal. Okay, occlusal view with the temporary restoration. And this is the OPG follow-up with the temporary restoration. Okay? So, what we can say at the end of this short lecture, nowadays we have another amazing option for our patient, thanks AB Dental products. With this option, now we can treat almost all of our patients, also patients in which we don't have bone. Okay, so thanks for your kind attention, and if you have any question, please feel free.
Thank you so much, Professor Cardarelli. Before we continue for question and answer session, I would like to remind you all that you can enter our events portal. I put the link in the chat for you, and you can check out there all of our future events and register. In November, we are going to have our next webinar with Professor Angelo Cardarelli, so you can already save your seat for the next one. And now I'm going to let all of you the permission to unmute yourselves, and you can go ahead and ask the professor any questions if you have any. Anyone wants to ask anything? Now it's the time. You can write in the chat or you can unmute yourself. Any questions from the audience? I see someone is writing Sanibel Oliviers. It's in Spanish. Unfortunately, we do not understand
I understood, I
Spanish.
understood, I understood, I
You
understood.
understand. Okay.
Yes, the incision, no, not in the crest. The incision always in the upper jaw, more palatally. In the lower jaw, more lingually. Not in the crest. Absolutely not. Why? Because on the upper, I want to move the connective tissue from the palatal side to the buccal side. The same in the lingual side, in the lower jaw, that we don't have enough tissue, connective tissue on the lingual, but the incision always a little bit lingual, never in the crest, never.
Okay, Mr. Fatin from Turkey is saying, thank you, Professor Angelo. Mr. Fatin, it was great seeing you this week in Athens.
Fatin is our amazing responsible in Istanbul, in Turkey. Thanks, Fatin, for your amazing work.
And we also see Professor Eli Raviv from Canada is here with us. Thank you for joining us. And also Professor
Was
Zvika
with me.
Schwartz is here.
Professor, he was in Punta Cana with me.
Yes.
I hope to visit
Correct.
him very soon. I hope.
Any questions?
Hello, my name is Dr. Sgouras from Athens, Greece. Do you hear me?
Yes.
Yes. Thank you for the presentation. It was very, very nice. I saw you. I have the opportunity to show you in Athens this weekend. And I want to ask that do we have any osseointegration of the frame with the bone?
We have the osseointegration for sure in terms of the screw. Regarding according to the latest publication, we can say not, we can say osseointegration because, as you know, for the osseointegration, we need that the implant is inside the bone. But for
Yes,
sure,
but
we have something almost like osseointegration compared with the previous customized implant. Okay?
yeah,
For sure,
good. So
it's, I mean, we can have close contact like healing between the bone and the customized implant, but for sure, the bone doesn't go on the top. It's impossible because the customized implant is on the top of the bone.
yes, yes, of course. Okay, thank you very much, doctor. Have a nice afternoon.
Same for you.
Okay, we have a question in the chat from Mandeep Singh Mata from India. He says fat layer is present between periosteum and epithelium. Please elaborate to exposure of fat layer again, was not clear.
That's why you need to join our courses with AB Dental. Then during I will show better, but I'm joking. So the fact is in the thickness of the tissue. Okay. So I don't know if you have experience with the cadaver dissection. And as I can say, exactly the fat is between the periosteum and the tissue, exactly in the thickness of the cheek. Okay, but in order to understand, the best way is to make some surgical incision on the cadaver head, and then you can reach easier and you can remain during your surgery, but is in the thickness of the cheek.
All right. Mr. Luis Rizzo says, thank you, Professor. AB can send implants to Guatemala. If this is possible, how much time can I have them here if I send the CBCT and the scan?
Yes, I think. All over the world they can send.
Sure, I will pass this message to Mr. Avi Ben Simon, the area manager of South America, and he will contact you.
But we don't have any limits with the CBCT all over the world. For sure, it's different. The shipment, it's different in terms of the time, but we don't have any limits.
Irit?
Yes. Hi,
Can you hear?
Hi, Professor
Oh,
Eli
Professor.
Raviv. Nice to see
you
you.
again. How are you? How was the weather in Canada?
Auguri, Angelo.
Grazie. Also, we can speak Italian.
Yeah. Come stai?
Bene, bene.
Okay, good. I miss you. Congratulations for your beautiful presentation.
Thank you.
And planning. Everything looks beautiful. So my congratulations to you.
Thank you very much. It's an honor for me.
I wasn't very clear about the loading issue.
Yes.
You mentioned at the beginning that one of the advantages of this type of treatment modality is that you save time,
Yes.
and you can immediately load this.
Yes, you have two options. You can do immediate loading or you can wait. I did different case to compare the immediate loading or the delayed, but you can do immediate loading as the standard implants.
Okay, so why did you wait 6 months on that patient with the right side, the first patient that you presented?
The right side, because I want to be sure to avoid during the loading some lateral force, okay? So in order to avoid any micro movement, to wait the osseointegration of the screw.
I totally agree with you, because I understand, and that's what I thought.
Also because the patient has already from many years this edentulous side, so in that case I prefer to reduce the risk, especially on the customized implant, because this is a new approach and we don't know what's happening in the future. So slowly. For sure, if we have a dentulous patient and we need to make immediate loading, we can do. But if we don't have we don't need, if we don't have the what I mean, the exigence from the patient to make immediate loading, it's better to wait, I think.
Yeah, I agree with you. Also, the intermaxillary distance was big. I mean,
Yes.
the
Yes.
crown to implant ratio was unfavorable.
Yes.
Which is something to consider when you have such atrophic maxilla and a huge intermaxillary distance. That's could compromise it, definitely.
Yes.
Okay, that's confirmed what I thought, and bellissimo.
Grazie.
We have another question from Jose Arroyo. He says, hello, Professor Cardarelli. Multi-units always come with predefined heights. Can it happen during surgery that these heights needs to be changed? Is there any abutment to this effect?
I think you can ask AB Dental for sure. you can take some impression of the soft tissue just to understand the thickness, but anyway, if we have a standard multi-unit abutment in terms of the height, you can manage with the suture and you can manage the tissue at during the surgery. Yes, you can see the height of the gums with the intraoral scan, as I told before. Exactly. So you can send the CBCT and the digital impression.
Irit,
All right. Yes.
can I ask another question?
Sure.
Angelo, what is the longest follow-up that you have on this implant system?
Actually, with this implant, I have actually almost 2 years.
Okay. So we cannot have the documentation and data of 5 years.
There are some doctors also in Evidenta that are using for I think 4 or 5 years. They have some follow-up, but actually we can't use. I think in the next year we have the authorization to use the customized implant in Europe officially. So now I'm using solely in a small group of patients because we don't have the legal approval in Europe. That's why.
I see. Okay. Good. But definitely there is a potential for the future.
Yes, potential, but as I told at the beginning, I'm using this approach as last chance. This is the last chance for the patient. If I have another option, I will use the other option. Okay? Young patient, no customized implant for sure, bone regeneration. But if we have old patient in which, for example, if we have the patient that comes with some previous failure, so we can propose the customized implant because this is the last option.
So you're telling me that this is your last resort, even if you have a case that you can place zygomatic implants and pterygoidal implants, would you prefer zygomatic over the 3D printed implant, the subperiosteal?
I prefer subperiosteal. Actually, subperiosteal.
Okay. So
it's easier to manage the issue. That's why.
Yeah. So this is the second to last.
Yes.
Okay.
In what case do you use fat flap always in the maxilla? In all cases.
Yeah.
All right. Any last questions from the audience?
Mille grazie.
Grazie.
Ciao.
Salutami
Okay, everyone. So thank you very much, Professor, for your time and all of your knowledge and for answering all of the questions.
We have another question in the meantime. No fat
Yeah.
in the mandible. No, because in the mandible we don't have the fat. In the mandible, how we can close? Using the flap just to make the incision with the periosteal, just to move the lingual flap to cover better. But as you know, this is an anatomical structure, the fat that we don't have in the mandible.
All right. Another one. Can we incorporate axial implants with SPI?
Yes,
Yeah.
exactly. Yes, you can do. If you have a ball, you can put one normal implant and customize it.
Anyone else wants to ask something? All right. So thank you very much, Professor Angelo Cardarelli, once again. I invite all of you to enter our events portal and register for the next webinar, which will be in November. And that's it. Have a good evening, everyone. Bye-bye.
Greetings from